Hello again, welcome back to Advanced Human Gross Anatomy. Today we have a doozy of a lecture today. We're going to go over the skull, the entire brain case, the cranium and face today in this one lecture. Understanding the skull is foundational to understanding the head and the neck. The skull is made up of 22 bones. 8 bones make up the cranium. This is what protects the brain. And 14 bones are facial bones. This is what make up the orbit, the nasal and oral cavities, and give us our facial features. So let's jump in and start talking about the skull. The first thing we'll talk about are the sutures. Sutures, when the Greeks looked at this, they thought they looked like these bones were sewn together. And it does kind of look like that, doesn't it? These jagged edges that kind of look like they're stitched together. So they call them sutures. There's the coronal suture, which is in the coronal plane. This is what's separating. This is anterior and posterior. The frontal bone here and the occipital bone back here. The coronal suture separates the frontal bone from the parietal bones right here. Here from the underside, you can see that coronal suture. This is looking from the brain up. This is on the inside of the skull here. The sagittal suture, you can see here, splitting the parietal bones here. It's in the sagittal plane. That makes sense. Coronal sutures in the coronal plane, sagittal sutures in the sagittal plane. Between the sagittal sutures between the coronal suture and the lambdoidal suture. Here's the lambdoid suture back here. This is what splits and goes around the occipital bone. You can kind of see it again from the underside here as it's down and around. Between the parietal bones and the occipital bones is the lambdoidal suture. Looks like the Greek letter lambda. I think that's probably where they named it that, because it kind of splits and goes around this way. And then the squamous suture. To see the squamous suture, we have to go to the side view of the skull here. This is going to separate the top portion of the temporal bone from the bottom portion of the parietal bones here. So between the temporal bone and the parietal bone is the squamous suture. Obviously, you've got 2 squamous sutures. One on the left is what you're looking at here, and then on the right side here again would be your coronal suture. Here's the left side of the lambdoidal suture that continues down the right, and then the sagittal would be on the top here, splitting the 2 parietal bones. If we take the top of the skull off, and this is what we'll do in lab in a bit here, but when we take the top of the skull, you can see this picture. It's a little difficult to see. I think Netter did a fantastic job of drawing this with shading here. You can see how there's like a ridge right here, and then this anterior cavity drops down into a middle cavity. And right here you can see there's another ridge, and then it drops down even further into a posterior cavity. So it looks like the middle cavity looks a little higher in cross-section here because, well, here, let's go to maybe a cross-sectional view of it. So here you can see the anterior, and then it drops down to this middle, and then it drops down to this posterior cavity here. The sphenoid bone raises up high in the middle here, so it kind of raises up like that. So you can see the edges. When you hold the skull, which you will have skulls in lab too, just models, it's much easier to see these 3 almost steps down as it goes from anterior down to middle, down to posterior. So we'll look at all these structures and that as we go along. Let's start our discussion of the skull bones with the frontal bone here. The frontal bone, this big bone. Wouldn't it be cool if our bones were color coordinated to make it all easy, like this drawing here? But this is the big blue bone here. So this forms the superior portion of the orbit. Right here, so on the top portion of each of the orbits, you'll see it has a frontal squama. This is the vertical plate. Squama means flat. So this vertical plate. Among primates, humans are unique in the vertical nature of this part of the skull. It accommodates, I would think, it would accommodate more of an elaborate precentral area of the cortex, which would allow for many things, complex social behaviors, understanding consequences, sequencing actions, etc. Those kinds of things would be housed in that frontal cortex. So this tall vertical nature of the frontal bone would accommodate for a larger um, uh, precentral area in the cortex. Anyway, the supraorbital margins right here. There's the supraorbital margin here, and on the left side, these ridges, a thickening of bone right above the eyebrows. You can feel down your own face. The nice part about anatomy, again, is that we all have it, so we can kind of feel on ourselves. The frontal sinus. To see the sinus, we have to go into a cross section. Let me show that section here. You can see this sinus. It's kind of hollow, a hollowing of the bone right between and above the orbits. So if you've ever had a pressure headache, like a sinus headache, let's go back to this picture here. You almost want to just push right here, like, if I could just take a drill bit and just release the pressure right here. You've got a filling of that sinus, that paranasal sinus, that you can see the space that it takes up. Let's go to this one right here. So that makes sense that pressure would be causing pain in that area. There's a supraorbital foramina. You got a couple of these right above, right at that supraorbital margin, are these holes here, these supraorbital foramina. This is where an artery emerges on each side. And travels up along that frontal plate, that vertical plate. A vein will enter as well, coming down, draining this area. And a branch of the trigeminal nerve, actually exits here, providing sensation over that area. So that's what's exiting and entering these supraorbital foramen here. Next, let's look at the parietal bones. You can see them here, easiest in cross section on the top, actually, just a superior view of this. They meet at the vertex, so the highest point, if I go to this shot here, maybe you can see it's just the highest point right here at the top of the skull, right at that sagittal suture. There's a superior and inferior temporal lines, which are right here. And so you can kind of see them right here and right here, those lines. And this is the origin for a powerful muscle called the temporalis, which we'll see in a little bit here. But this inserts onto the coronoid process, down kind of through the zygomatic arch, right onto that coronoid process of the mandible for elevating the jaw in chewing, mastication. That's it for the parietal bones. Now we'll get to the temporal bone. This is going to be a doozy here. The temporal bone, there's a lot to talk about. Lots of little things here. Now, the name temporal, tempo, think of words like temporary or tempo in music. Time. This is what it's referring to, time. The Greeks noticed that men's hair often grayed in this area first, kind of on the sides of their head here, the temples. And they thought, that must have something to do with time. That's the story I've heard, and I like that story. It makes sense to me, and I always like kind of knowing, where did this stuff come from? So the temporal bone here, right on the sides of the skull, there's a process called the zygomatic arch right here. The zygomatic process makes up part of that zygomatic arch. The other part comes from the zygomatic bone. There's a temporal process that meets the zygomatic process, but they're named for where they're going, what bone they connect to, not which bone they're a part of. So the temporal process would be part of the zygomatic bone. The zygomatic process is part of the temporal bone. So hopefully that doesn't get confused there. So it reaches towards that zygomatic bone and joins the temporal process of the zygomatic bone to form that zygomatic arch. So it's a part of the prominence of the cheek. So if you can kind of feel even on yourself, you'll notice where the zygomatic bone, the prominent cheekbone, kind of wraps around toward the side. There's a petrous portion. Now, petrous is going toward the center from the base of the zygomatic arch here. So you're kind of coming from here but going in. I think it's easier to see from here. So imagine that zygomatic process coming from here. The petrous portion is this portion on the inside. Petrous means rock. It's kind of where we get words like petrified or Peter, the rock. where the who was the name for Peter was the rock where the church was going to be formed. That's this portion here. It kind of looks like a rock here. It contacts it contains rather the inner and the middle ear cavity, right inside of this. So if, later on we can kind of chisel into this and start to find, maybe we'll find some ossicles from that middle ear cavity. So it's a ridge along the posterior part of this middle cavity here of the cranium. You can feel that ridge right down, and it drops off to the bottom side here. So there's a hole in the front of this where the carotid artery comes out. Right there is where the carotid artery enters the cranium before passing alongside the body of the sphenoid. So it's going to come across and then travel up the body of the sphenoid here. The carotid canal actually starts in the skull about halfway back in the petrous portion, right here of the temporal bone. I think it's maybe easier to see here. You can see where the carotid artery is going to enter, the internal carotid artery is going to enter, and then it's going to travel across this way. And this is right about here is where we see that on this side, where it enters that cranium right there. So the carotid artery passes right by, goes right through the petrous portion here. It kind of passes right by the middle and inner ear. Have you ever been in a quiet place, or maybe out in nature in the winter when the snow is out, that muffles the sound, and you can hear your heartbeat? You can kind of feel your pulse when you're in a quiet place. That's because those ossicles are right there. The inner ear is right here. And the carotid artery goes right through the carotid canal, right next to those areas here. Let's see, the internal jugular vein, you can see where that's going to enter, it's going to exit the brain right here. The internal jugular is going to exit there. It joins with the internal carotid artery. They're kind of wrapped in the same connective tissue sheath at the start of that carotid canal. So if we go back to the bottom here would be where that jugular foramen is going to be. And then you can see right here is where that internal carotid enters. And so right there, they're kind of contained in that same kind of a connective tissue sheath right at within that temporal bone. The foramen lucerum, you can see it on the underside here. I think we'll go to this picture to see it, where the internal carotid artery enters, kind of exits the carotid. Boy, easy for me to say. As the internal carotid goes through the carotid canal in that temporal bone and exits this the carotid foramen here, it's going to go right across this foramen lucerum, which is where it's going to exit and come right across this way. It's going to travel up then the body of the sphenoid right through here. Now in the living person, that foramen lucerum is covered with some cartilage. So we won't be able to see that on the models, but we might be able to see that still on our cadavers here. There's one autonomic nerve that passes through that foramen lucerum here, right through there. The jugular foramen, again, is where the internal jugular vein exits. And we already kind of talked about that there. Let's see, I don't know if there's anything else that I wanted to say about this. So the jugular foramen, you can see that big space right through here from the underside. Let's go to this space. It's right here, the jugular foramen. This is going to be where several things go through this canal here. The sigmoid sinus drains right into here. The sigmoid sinus is going to kind of wrap around here and then drain into the internal jugular vein. And it will flow out. Cranial nerves number 9, the glossopharyngeal nerve here, sensation and motor to the throat. Cranial nerve number 11, motor sensation to sternocleidomastoid and the upper trapezius. The spinal accessory nerve exits right through there. And cranial nerve number 10, the vagus nerve, a big one, responsible for most of our parasympathetic output to our body, exits through that jugular foramen as well. So a lot going on over there. Now, the petrous portion, let's talk a little bit more about this. Let's look at the bottom of the skull here. You can see where that jugular foramen is right next to that carotid foramen. And so right here, they're very close here, but then there's that carotid canal, and the exit of that isn't going to happen until right here, right next to that foramen lucerum. So back where they're on the underside here, where the jugular and the carotid, the internal jugular and internal carotid, they're kind of wrapped in that same fascia sheath together. So then when they travel through the carotid canal and it exits on top of foramen lucerum right through here, and it goes up the side of the sphenoid and then branches off from there. The jaw, let's see, has been removed here. So you can see, let's see, right here would be this mandibular fossa here. You can see that where the, right in that petrous portion where this is going to be this depression, right here where the mandible would sit, and this is what gives the articulation with the jaw, the temporomandibular joint. Here's the temporal portion of that joint. Okay, on the back side of the temporal bone here is this mastoid process, or this portion on the back side right through here. You can feel it right behind your ear. There's kind of a bridge of bone right there. You can feel where your ear is. You can kind of come behind the lobe, and you'll feel that right there. This is where in the clinic you would do traction. If you were going to hook somebody up to a traction table or pull on somebody's head, this is a nice place to grab. They used to pull on people's jaws to do traction. Then they realized it was really cranking up their temporomandibular joints and creating dysfunction there. So now we just grab on the skull. So if you felt that, you should be able to notice where the sternocleidomastoid attaches to help move the head right at that mastoid portion. This can sometimes get infected. Mastoiditis is sometimes common in younger kids. It's not very this bump here, the mastoid portion, is not very prominent at birth. And as the baby starts lifting their head and moving their head, kind of engaging that sternocleidomastoid more and more, it will start to alter the shape of this and start to pull down. That's where it really gets its shape as with the muscle contractions there. This pulling on the bone, though, creates some cavernous spaces within this portion that are continuous with the middle ear. And so that middle ear infections can spread to the mastoid portion of the temporal bone here, just because it kind of pulls apart and there's a little connection in there. So it's lined with a mucous membrane that's continuous with the mucous membrane from the middle ear as well. So middle ear infections are more common in children, especially because of their eustachian tube is still very, it's not quite as vertical as it will get. So infections from nasal cavities are easily transmitted, more easily transmitted to the middle ear in children. And if that's the case, then it can kind of spread to the mastoid portion. So mastoiditis. External auditory meatus, you can see that opening right here for the ear canal. In the living person, about half of the external auditory, about half of the ear, that outer portion is cartilage, and the other half is within the bone of the temporal bone there. There's an internal auditory meatus as well. You can see here as it goes through that temporal bone. Into there. Cranial nerves number 7, the facial nerve, comes through here, as well as cranial nerve number 8, the auditory, where vestibulocochlear nerve passes through this as well. The vestibulocochlear nerve passes into the internal auditory meatus from the cranium, you can see there, and then the facial nerve travels through there, through the temporal bone to exit onto the face through there as well. The pterygotympanic fissure, the petrotympanic fissure, immediately posterior to the mandible. Let's find a picture here. So kind of this fissure right here, just posterior to the mandible. The tympanic fissure. This is where a nerve called the chordae tympani is going to come out. And this is a little nerve exiting here. We'll jump on to the lingual nerve for taste sensation at the anterior 2/3 of the tongue. It's part of the facial nerve, but this is what the facial nerve we talk about being both motor and sensory. Motor to the tongue, but also sensory, and that the sensory component is due to the chordae tympani nerve, which is coming right through that the petrotympanic fissure right behind the mandible. The hiatus for the greater and lesser petrosal nerves. Let's take a look here and see these here. The greater and lesser petrosal nerves, these are inside the cranium, two small grooves with a foramen for the petrosal nerves coming from the petrous portion of the temporal bone. This is part of the autonomics of the neck. You can see here the greater and lesser petrosal nerves are going to kind of lay right on the top portion right there. The endolymphatic duct opens in the cranium behind the external auditory meatus, kind of right in through here. The endolymphatic duct. This is kind of in the posterior portion of the petrous portion. This connects with the endolymphatic sac, which connects with the cochlear duct and the inner ear. So it's kind of lateral and posterior, to the internal auditory meatus, kind of right back in here. Okay, the temporal bone. How did we do? Okay, let's go to the occipital bone. The occipital bone here, the first thing to look at, this is on the bone of the back of the skull and the posterior inferior portion of the skull as well. There's a foramen magnum. Now, foramen means whole, magnum means large or big. So when the Greeks saw this, they said, "Oh, that looks like a big hole. Let's call it the foramen magnum." So that's where that gets its name. This is where the brainstem exits the cranium and becomes the spinal cord, or the spinal cord comes into the cranium and becomes the brainstem. There's occipital condyles. You can see the one here. There's one on the other side as well. Maybe easier to see. Nope. Let's find this one. Here's a kind of a cross section. You can see the right occipital condyle right here. This is kind of a big rocker on either side of the foramen magnum. Let's maybe go to this picture here. You can see them. But these two rockers on either side of that foramen magnum, this is where it's going to contact. It rests on vertebrae number 1. Remember, condyle is where two bones articulate, so that's where that name gets its. Or that's where that gets its name. But it's going to rest on the atlas. Remember, Greek mythology, Atlas was that god that held the world on his shoulders, the world being the head in this picture, and the first vertebrae being Atlas. And here you can see these rockers that sit right on there. They allow for you to nod yes. So let's look back at this. If you kind of see the rocker here kind of going back and forth, front and back. So it's like the down and back stroke of a yes nod, if you're gonna kind of nod yes to somebody. On the back of the skull here, you can see it's a nice cross section. This kind of bump right there. You can feel it on the back of your own. It's kind of where the occipital bone comes straight down. That kind of makes this angle on the way in right there. We call that the external occipital protuberance, or the inion. Another name for that. This big bump right back there. It's kind of obvious. It's for a site for muscle attachment. There's a superior and inferior neutral lines here. There's an inferior and the superior neutral lines that kind of come across from that inion and then inferior to that. This is where the neutral ligament, or the ligamentum nuchae, attaches. Also muscle attachment sites on each side of that. There's a groove for the sagittal sinus. So let's take a look here. Here you can see this groove for the sagittal sinus coming straight down. And then it would actually come across this way to this transverse sinus. So the starts on the underside of the skull, actually. Let's go back to this picture. When we looked at sutures, here's a good shot of the top of the skull looking from the bottom up. So from where the brain sits, looking up at the skull. And you can see on the underside here, where that sagittal sinus, you can see the groove where that would sit here, coming along there. So once it gets to the occipital bone, it just continues down. It travels down, and then laterally, let's go back to this picture. Sorry, lots of switching of pictures here. So that sagittal sinus comes down, and then it kind of comes in here and then splits, and it's going to go left and right to the transverse sinuses. And then they snake down this way to that sigmoid sinus, which is eventually going to enter into that jugular foramen and flow into that internal jugular vein right there. And right here on the sides of the sigmoid sinus, you can see there's these little pits on the sides here. And these little pits are places where the arachnoid granulations protruded into that sinus for reabsorption of the cerebrospinal fluid, and this is where the bone has ossified around them when they were in place. There's a confluence of the sinuses, which is kind of right here, and you can see where where the superior sagittal sinus is going to come in and meet it's going to split then to become the transverse sinuses on either side. If we go to a different shot here, this is going to look more at that vasculature, but maybe that's easier to see. Here's that sagittal sinus, superior sagittal sinus right here. There's an inferior sagittal sinus kind of under right here. That's going to be kind of over that corpus callosum right here. That's going to drain into the straight sinus, which comes in right at midline, but then it's going to split to have those transverse sinuses on each side. Here we're just looking at the right side, obviously, but that straight sinus comes into the confluence of sinuses. That transverse sinus goes to the sigmoid sinus, where it will then enter into the jugular foramen, right there, meeting the internal jugular vein. Okay, let's talk now about the sphenoid bone. Sphenoid's a funny bone here. It's a unique bone. It's where we get the name keystone. It's a wedge right here. You can see it actually has when you think of a wedge, think of the center stone on the top of an arch. The Greeks were big into their architecture with arches. It's really a fundamental to the integrity of the arch is that keystone or the wedge. What's unique about this sphenoid, it has attachments to all the other cranial bones. So to the frontal bone, to the parietal bone, to the temporal bone. Let's see here, you can see a little bit to the ethmoid bone, but let's see here, it comes in, here's the big sphenoid, comes into the ethmoid bone and the occipital bone. This is probably a better shot where you can see all of the attachments. So when the Greeks looked at this, they said, "Oh man, that attaches to everything." It really looks like it's the glue holding it all. It's the wedge holding it all together. So the sphenoid bone is right here. It has a body to it. You can see the body. I think it's easier to see the body in this picture, where it's this big block portion right there. It contains the sinus. There's a hollow portion inside. Again, just like the frontal sinus, the sphenoid has a sinus here. Along with the frontal sinus, these are lined with a mucous membrane and drain into the nasal cavity eventually. There's a sella turcica. This looks like a saddle. You can see it right there. Sella turcica literally means the Turkish saddle. Maybe another shot of that would be right here. You can see the body going straight into the plane of the picture here, but the saddle here, the sella turcica, right there. This is where it's also called the hypophyseal fossa. It's where the pituitary gland sits. I don't know where it got its name, the Turkish saddle. Is it because the Turks and the Greeks were often in conflict? Is it a pejorative name, or is it just named because it looks like the shape of the Turkish saddle? I don't know the answer, but I think it's funny that we still call it the sella turcica, the Turkish saddle. And the sphenoid has greater wings and lesser wings. And one way I learned this is just to say that the greater wings are kind of on the bottom, they're coming down that shelf from the anterior to the middle cavity, and they're mostly down on the front side on the bottom here, and the lesser wings are kind of in the anterior cavity on the top. So the greater wings coming out laterally from the body, into the middle cavity of the cranium, and the lesser wings entering the anterior portion up on top here. A couple things that are important in a couple structures from the sphenoid bone here. The optic foramen right here, this portion right here, is the kind of anterior and lateral to each side of that saddle in that lesser wing on each side. The carotid artery travels by this. So remember, that carotid artery comes through here, goes over foramen lucerum, comes up the body, and then kind of goes right through there. And a branch of it, the branch of the internal carotid called the ophthalmic artery, supplies the orbit. It's going to go through there and supply the orbit. The optic nerve, cranial nerve number 2, comes out back through this optic foramen there, on its way back to the lateral geniculate nucleus, and on its way back to the occipital lobe, and then eventually to the primary visual cortex back in the occipital lobe of the brain. That's that. I think maybe we can see that through this picture as well. You can see the optic foramen right here. It's that small hole right next to the kind of back behind that orbital plate there. Let's go to the superior orbital fissure. Here's an easy place to see that as well. Here's that fissure on the right eye. Here's the optic canal. Here's the optic foramen, and then the superior orbital fissure right next to it. A long crack here. Let's go back to this picture. It's kind of between the lesser and greater wings, kind of right through here. You can't really see it. It's right underneath the lip there. Cranial nerves number 3, 4, and 6. Those go together because they're all motor innervation to the eye. They're all going to the eye through this fissure. So the number 3, the oculomotor. Number 4, the trochlear, and number 6, the abducens on each side is going through that superior orbital fissure. Okay, cranial nerve number 5, the ophthalmic branch, V1 they call that, of cranial nerve number 5, the trigeminal nerve, but the ophthalmic branch of that goes through this as well. This is going to exit this the orbit on its way to the anterior and front part of the face here, so to the anterior frontal bone. So that ophthalmic branch of the trigeminal nerve is going to exit through the superior orbital fissure, go kind of in through the orbit, and then exit up that onto the frontal, the squamous portion there of the frontal bone. The pterygoid processes. These are funny looking things here. Let's look in the bottom of the skull. The sphenoid bone has these wings that come down. There's a medial and a lateral. Here's a medial and the lateral, which would be over here on the other side. Pterygoid processes. There's a muscle attachment. These are for muscle attachment sites, for muscles that connect to the mandible, for protruding the jaw right through here. Let me try to find a different angle. Here you can see that lateral and then the medial pterygoid process there. I think let's go to this view. Here you can just see the medial and the lateral is kind of behind it on the right side. These pterygoid processes hooking down. So from the body, the sella turcica, the sinus, and then right down below that would be that medial and lateral pterygoid processes. The hamulus is kind of the hook at the end. You can see on the medial side here is kind of a hook right through there on the medial pterygoid process, and that's for a muscle called the tensor vili palatini. That's a muscle that kind of hooks around the hamulus there and then goes kind of sideways. So it's going to come across, let me show it on this picture. It's going to come across here and then hook around that as it goes to the back, kind of traveling horizontally across the top of the throat. And when this muscle tenses on each side, kind of hooking around that, it's going to raise the soft palate behind there. Behind the hard palate, which is here, behind the maxilla and the lacrimal bone is the soft palate. You can imagine that muscle hooking around the hamulus on each side, creating that tension. Tensor vili palatini. We'll talk about that later. More about the sphenoid bone. A couple things on the inside. Let's go back to here. There's a couple of holes here. So we've talked about the optic foramen. We've talked about the superior orbital fissure. And then we'll just follow this down. Here's the foramen rotundum. And then behind that, the foramen ovale, the round hole and the oval hole. cleverly named. The foramen rotundum here, this round hole, kind of right there in the middle cranial cavity, it's where the exit for the maxillary branch, so V2 of the trigeminal nerve, cranial nerve number 5, that second branch, the maxillary branch, supplies the upper jaw with sensation, goes right through foramen rotundum. And then behind that, foramen ovale, trigeminal has 3 branches. We've learned the ophthalmic, the maxillary, and then the mandibular branch here. This oval-shaped hole in the middle cranial cavity exits the mandibular branch of the trigeminal nerve, V3. This supplies sensation over the lower jaw, also carries motor fibers for muscles of mastication right through there. The pterion is this portion right here. The pterion is where is this junctional zone here, where all these bones come together: the frontal bone, the parietal bone, the temporal bone, the sphenoid bone, one on each side, and it's right there. This is where all those joints, all those bones meet, but it's not really fully ossified at birth. This is actually the sphenoidal or the anterolateral fontanelle. We'll talk about the fontanelles at the end of this lecture. And this never really gets very dense and get well ossified, so it's pretty vulnerable. It's a tough spot to get hit with a blunt trauma. So if you ever see anybody hitting someone else, kind of in their side of their head, there, just politely tell them to stop. Tell them that's a pretty vulnerable spot to hit somebody, but maybe if they're hitting them, they don't really care about the pterion. But it's always a good time to learn some anatomy. The pterygoid canal, this is descending down the front of these pterygoid processes, right here. The pterygoid canal, passing through the inferior body of the sphenoid, carries a nerve and arteries that will supply the palate, kind of right between the pterygoid process and the palatine bones here. Maybe, tough to see there, kind of right in through there, between the palatine and pterygoid processes. Okay, let's keep rolling here. The ethmoid bone. Let's look at this picture first here, the ethmoid. Whenever I think of ethmoid, I always go right to the front of the skull and see the vertical plate here. This is a complicated bone. The lower part of the septum, you can see it right through here. But the lower part of the septum is made up of the vomer. You can see the vomer here. Oh, maybe we go to a different view. I wanted to go from the front, but I don't think it's going to work. Here you can see the septum cut in half. The lower part is this vomer. We'll talk about the vomer. It means plow. Kind of looks like a plow from 2,000 years ago, doesn't it? But the upper portion here is the perpendicular plate of the ethmoid. Okay, so that really is what forms the upper portion of the nasal septum in midline. So you can see, going back to my midline shot here, you can see the vomer is that little section right above the maxilla, and then the perpendicular plate here, you can see right there, is the perpendicular plate of the ethmoid. The lateral walls are actually a kind of a honeycombed shape, and they're full of ethmoid air cells. So that's really, it's kind of the collection of the, let's go to a different shot here, kind of a collection of those ethmoid air cells is what we call the ethmoid sinus. So again, that is still a sinus draining into the all part of that paranasal cavity here. But collectively, we call that the ethmoid sinus, which is also drains it into the nasal cavity, like I said. But these lateral masses here, or these labyrinths, are formed around that. So the labyrinth was, remember this. In Greek mythology, the maze with a monster at the end of it was the labyrinth. And so that's kind of what they thought this might look like on the side there. On the top, you can see on the very top of that perpendicular plate is this cribiform plate. And that goes more horizontally. It's kind of right at the base of the anterior cavity of the cranium. And above crib, you can see it maybe, well, let's go to the anterior. Let's go into this. So here you can see all these holes. So cribba means hole. It's where we still are opening. We still get, think of a baby crib. Has holes or slats, openings. A corn crib has holes and slats for drying the corn. Cribbage board has these holes. So it kind of looks like that. Crib means holes. And so The plate there, if form having the shape of crib holes, so it looks like it has holes. That's how they named it. Where the olfactory nerves are going to come up from the traveling through the nasal cavity to synapse on the olfactory bulb, which is going to sit right on top of the cribiform plate here, and then the olfactory tract comes straight back and goes right to the cortex. Does not synapse in the thalamus. It goes right to the cortex. Only cranial nerve that does that. Also, this is the exit for arteries. They're going to come down from the cranium to the nasal cavity for nutrition there. Right in the midline here, you can see the crista galli, or this rooster's comb, this kind of this big spike that sticks up. If we go from the side view again, maybe easier to see. That cribiform plate sits here, the kind of the bottom of that anterior cavity, and then that crista galli sits right on top of that. All part of the that's the midline of that cribiform plate, but it's all part of that ethmoid bone. The superior and middle nasal concha. These are kind of these shells here, shells of bone covering those lateral masses. When air comes through here, it will create turbulence when air is inhaled through the nose, and that's good because it helps to filter and humidify. It's also lined with a kind of a very vascular tissue and a mucous membrane, these lateral masses. And that's helpful for when air is inhaled, it's filtered, so by the little particles in the air get stuck to that lining that's around these superior and middle nasal concha. And then that mucus, along with whatever was filtered through there that got caught, will eventually kind of drain down the back of the throat. That's kind of what you wanted to talk about right now, huh? But that's if it accelerates, if there's a lot of material going on back there, lots of mucus being produced by those goblet cells, they'll create some postnasal drip, and that's where it's going to kind of be unpleasant down the back of the throat there. There's an inferior nasal concha as well, but that's a facial bone. That's not part of the ethmoid bone down here. So don't get that confused with the ethmoid bone. There's a superior and middle meatus, which are kind of these spaces between the concha. So between the superior and the middle, and between the middle and the inferior would be these meatuses here. This helps again to warm and humidify and filter the air as you breathe through your nose. There's an anterior and posterior ethmoidal foramen. This is in the orbit. If we go back to, if I can find my orbit picture. There you go. So the anterior and middle ethmoidal, oh here, I was looking up here, but here's a close-up for me. So the anterior and the posterior ethmoidal foramina. This is where the anterior and posterior ethmoidal arteries and nerves go through these. They're going to enter the cranial cavity. They cross the cribiform plate. They're going to come up and cross the cribiform plate and then drop into the nasal cavity on their way down to help supply that area with nutrition and sensation. So again, that carotid artery, remember the carotid artery coming through, going up that, the sphenoid, going, and then that ophthalmic nerve, the carotid artery is going to split and go into the a branch of that would become the ophthalmic artery, and then you're going to get these ethmoidal arteries off of the ophthalmic coming through here, and then dropping down into the cribiform plate to supply the nasal cavity. Okay, how are we doing? I think, oh my goodness, is that the end of the skull already? All right. Now let's talk about the face. There's 14 bones in the face. Let's start with the nasal bone here. Right up on top. This is where the bridge of your glasses would sit if you're wearing glasses. It's the only bone of the nose, actually. The only bone of the nose is actually at the bridge here, right way up here. The rest of this is just external. The external nose here is just cartilage that sits right in front of that. Let's see here. I guess that's all we'll talk about. The maxilla. Let's talk about the maxilla. Is this bone here? Maxilla is singular. Maxillae, M-A-X-I-L-L-A-E. If you put an E at the end, it's plural. It's actually a paired bone. So if we look on the underside here with the mandible gone, you can see the maxilla, how it's paired. It comes together in midline. So it forms part of the orbit, kind of the inferior portion of that orbit. Also forms part of the lateral walls and the floor of the nasal cavity. You can see the floor and the lateral walls of the nasal cavity. Forms part of the roof of the oral cavity. There's a lot going on with the maxilla. It's kind of a big deal. Those portions we saw underneath that come together, these are called the palatine processes. So don't get that confused with the palatine bone. These are the processes that connect to the palatine bone, but they're on the underside. They're the top of the anterior portion of that hard palate. These grow across from lateral to medial on each side, and they fuse at midline. Most people have a little ridge there where it just keeps growing just a little bit after they've connected. You can feel it with your tongue, maybe a finger at the top of your mouth. Maybe you've got a ridge right there. What happens, though, in a percentage of the population, and we don't know why, but these processes will come together, and then for some reason, one side will die back a little bit. It's about and I've read 1 in 700 have a cleft palate where it kind of dies back or regresses backwards then. And because that maxilla bone forms the upper lip, you'll also be missing one of the incisors right through here because you won't have that portion anymore. And you'll probably have it often goes along with a cleft lip. So cleft lip and cleft palate are very close together. You can do grafts to get these repaired to kind of bridge that space in between those palatine processes. These often go unfixed in underdeveloped countries, often a site of mission work for surgeons to go and fix those for kids that have had that, who have been born with that deformity. The maxilla, if I go to a side view here again, also has a sinus. Oh, let's see. Maybe I can't find that one. No, it also has a sinus. It's hollow. It's got that part of it. I'm not going to be able to find a picture there of the sinus of the maxilla, but it does have a sinus as well. There's alveolar processes, which you can see. Probably go back to this one. The alveolar processes are where the teeth come in. These are going to be sockets for the teeth right through here. There's an inferior orbital fissure. Remember the superior orbital fissure of the sphenoid bone. The inferior orbital fissure is right there between the sphenoid and the maxilla. And that's going to be where there's an artery branch, and a branch of the artery from the maxillary artery is going to come out there. And a nerve branch from the maxillary division of cranial nerve number 5. And remember the trigeminal nerve. Another branch is going to exit through here. These will lay on the floor of the orbit. You can kind of see a groove here. Here's a nice groove. You can see that groove right here. It's going to in the maxilla, and this is what's going to eventually enter through the infraorbital foramina. It's going to go through a tunnel here and exit that infraorbital foramina and supply the lateral side of the nose on each side. So those arteries and nerves coming out through there go through the maxilla. There's where they enter. There's where they exit, coming down there. There's an incisive foramen. An incisive fossa, or the foramen or canal. Let's look on the bottom side again here. That's this portion right here, right behind the incisors. In midline. There's a palatine artery and nerves that travel kind of back from that palate, from posterior lateral to anterior medial, kind of come this way on each side, and they'll enter this foramen and supply a small portion of the inferior septum with some nutrition and sensation. But there's also, coming out of here, is a septal artery and nerve coming through that incisive foramen and supplying a little of the anterior palate. So why, it seems funny, right? I have no idea why this is even here. Why do we have nerves coming from here going to the side, going to the septum, and why do we have an artery and nerve coming from the septum coming down to the palate? I don't know. The alveolar foramina, again, these small holes. Let's see, go back to here. Oh, yeah, right here you can see the alveolar foramina, these small holes kind of on the posterior aspect of the maxilla above the molars. This is where a nerve and arteries supply this area. These are coming, that artery from the maxillary artery is going to come out right here and give nutrition to there. This is an important space for dentists to know, because this is where that nerve is going to come out. This is where you need to get numbed for dental work on the upper jaw. That superior alveolar nerve comes right out of here and supplies sensation to that upper jaw. So if you have work done on your teeth, this is what's going to kind of give you a dulled sensation over that area. If they can put an injection of Novocaine or some type of numbing agent right into that space there. Okay, let's talk about the zygomatic bone. As long as we're on this picture here, the zygomatic bone, the temporal process of the zygomatic bone meets up with the zygomatic process of the temporal bone. If that's confusing to you, just say it over and over, and it'll maybe make sense later. But again, they're named for where they're going, not the bone that they're on. So the temporal process is on the zygomatic bone, going to the temporal bone. And that's what together that makes up that zygomatic arch. Now, I don't have a, here's a good shot of it. There's an underside. So from when you're holding a skull, just a model in the lab, you'll be able to kind of have it be a handhold almost. You can put a couple of fingers in here. So that temporal process right here meets the zygomatic process, together making the full arch. Okay, zygomaticofacial foramina. Let's see, zygomaticofacial foramina. Kind of right in through here. That's where there's a little hole right there, where a small hole where nerves will travel, giving sensation to that area, the zygomaticofacial. Zygomaticotemporal foramina. It's kind of on the back side, small hole on the back of the temporal process. I don't have a great picture of how to show that, but where a nerve will supply the sensation to that area as well. So zygomaticofacial, zygomaticotemporal, temporal foramina. Okay, the mandible. Here's the mandible, the only movable bone in the skull. Has a body. You can see just where the body is. Here's a different shot of it. Let's go to this one. The body is just this main portion. If you grabbed your jaw, grab your face from under, if you put your fingers in your bottom jaw and then put your thumb underneath your chin and grab, you'd be on the body. I don't know why you do that, but that's where it is. There's an angle right here from the body that will shift into a ramus. And the ramus, it means arm. So that's just a straight arm here coming right off of the body, where it will meet then into the temporal bone here. So this there's a condylar process there. Again, the angle is just where it comes down and meets into the body. So ramus, angle, mandible. When I was a kid, Christopher Reeves was a superhero, and I think that was one of the prerequisites to become Superman, was he had to have a very good angle of his mandible to become a superhero in Hollywood back in the 80s. The condylar process. This is what's going to be on the top portion right here, the top of the ramus that articulates with the mandible. So remember, condyles are points of articulation. So making that temporomandibular joint. Imagine that condylar process fitting right into this. Well, here you can see it kind of fits right into that groove of the temporal bone. There's a coronoid process, which is this front portion right here. Let's go back to this picture. So the condylar process, and then the coronoid process right here. Coronoid, you've seen a coronoid already with the ulna, the anterior portion of the ulna. Proximal anterior portion. There's a coracoid process of the scapula. All of these mean beak, so it kind of looks like a beak, doesn't it? Kind of right up like this. Attachment site for the temporalis, which is, remember that muscle that comes up from these those temporal lines, those inferior and superior temporal lines. It goes down through the zygomatic arch and attaches to the coronoid process, a powerful muscle to elevate the mandible. There's alveolar processes, again, just like the maxilla where the teeth are. Well, that's going to kind of be contained where the sockets are in the teeth, just like the maxilla. There's a mental foramen. Now, mental, you think, mental means chin. It has nothing to do with mental capacity or thought process. It has nothing to do with your brain. Mentum means chin, and so the mental foramina is here on the front of the skull. You can see there are two of them. There's a mental foramina here and a mental foramen there. The two foramina. This is where the inferior alveolar nerve and artery pass through the mandibular foramen. So this is inside the mandible. So the mandibular foramen is actually way up here. So that inferior alveolar nerve and artery pass through there. They travel through the mandible, kind of right through inside the bone. And then they provide sensation to the lower jaw. They exit here, the inferior alveolar nerve and artery, to become the mental nerve and artery. So as they exit, they change their name and they supply that lower lip and chin. Again, this is an important part right back here because that inferior alveolar nerve and artery are going to be what supplies the lower jaw with sensation. So if you have dental work again on the lower part here, they would want to put a numbing agent right back here, injecting into this space to numb that inferior alveolar nerve. This is why when that is done, when the dental work is done, it's always a little embarrassing to drink water or eat something because you can't feel the bottom of your jaw, so it just falls out, right? We've all experienced that, I think. Maybe not. If you haven't, ask for it next time. Okay, the lacrimal bones. So you can see them right here, these purple bones right there and right there. The lacrimal bones are very thin, thinnest bones in the skull. They're right at the medial portion of the orbit. If you push hard right here, you can crack it. I've never seen that, but I'm told that you can break them because they are thin and small. They have a depression in them. You can see right through here. There's a little crease where the lacrimal sac is. That drains the medial aspect of the orbit. It goes right through here. There's a nasolacrimal duct that goes from there down into the nasal cavity. This is what kind of under that inferior meatus. This is why when you cry or when you've got when you have allergies or if there's moisture going over the eye, it's going to enter into that canal, and then this is why you have a runny nose, because it goes right through that lacrimal bone down into there. The palatine bones. This is a funny looking bone, the palatine bones. But we've seen them already a little. Let's look at this picture here. This is the back portion of the hard palate. It's where the palatine processes of the maxilla are going to attach on the back. But it's really like a big L. If we go to this picture here, you can see in midline, it's going laterally and then vertically. So it looks like a big L, or a backwards L, depending on which side of the skull you're on. But imagine these going laterally and then vertically, lateral and then vertical from here. So the horizontal plates are what meet the lacrimal, the palatine processes of the maxilla meet the horizontal plates of the palatine bone. Boy, that does get tricky to say. On the lateral edges, again, they'll go vertically and they'll turn 90 degrees and go up, kind of making that L shape right in front of the pterygoid processes. You can see where the pterygoid processes are here, the medial and lateral on this side, going horizontal and then vertical. Right into there. The greater palatine foramen, there's a nerve, an artery and vein. You can see the greater and then the lesser right behind it here. That's where there's an artery, nerve, and vein going through the pterygopalatine canal, supplying that hard palate, coming up this way and then wrapping around. There's a lesser palatine foramen right behind there. You can see where there's two smaller holes behind the greater palatine foramen. Again, a nerve, artery, and vein going through there to supply the soft palate coming back. This is not, again, the soft palate's not on the skull because it is cartilage. The greater and lesser palatine canals, well, if there's a greater and lesser palatine foramen, I guess they're going to go traveling down the greater and lesser palatine foramen are the canals. So that makes sense where their names would be right alongside of that. The sphenopalatine foramen, you can see this from the side. So let's get rid of the zygomatic arch here. The sphenopalatine foramen is right at the top of the pterygopalatine fossa, kind of right in between the maxilla and the between the maxilla and the sphenoid, the pterygoid processes here, but then right up into the base of the palatine bone. So these dive into the pterygopalatine fossa, and it's at the top of the palatine bone between the maxilla and the pterygoid processes, like I said. The maxillary artery is going to go right in through here. It comes along deep in the face, and then the terminal branch enters that sphenopalatine foramen right up in here to become the sphenopalatine artery. This is what's going to supply a major part of the back of the nasal cavity from the inside. Right in through that hole there. If we go to this picture, remember we talked about the inferior nasal concha before, but we were talking about the ethmoid bone here, but the inferior nasal concha is a bone all by itself, inferior to the superior and the middle nasal concha of the ethmoid bones. You can see it also on the front of the skull right here, the inferior nasal concha on each side. The vomer, we've said already, is kind of the inferior portion of the nasal septum right underneath the perpendicular plate of the ethmoid. It looks like a big plow in cross section, a plow blade anyway, right through here, so they called it the plow. It is the majority of the posterior portion of the septum. It kind of makes this, the ethmoid bone is the majority of the anterior portion, the vomer is the majority of the posterior portion of the nasal septum. Kind of narrows anteriorly. The hyoid bone, a couple things about the hyoid bone here. The hyoid bone, if you kind of feel your thyroid cartilage, your Adam's apple, and you go down just a little bit further from that, and you'll feel this this funny bone here. It's the only bone in the whole body that doesn't articulate with any other bone. It's kind of interesting. It's just kind of held together by ligaments and muscle attachment sites here. So it's an arch-shaped bone about halfway between the bottom of the mandible. Feel the mandible, feel the thyroid cartilage, again, your Adam's apple. If you go up from the Adam's apple and kind of right between that and the body of the mandible, you'll feel this bone that you can kind of wiggle around in your neck there between the mandible and the thyroid cartilage. The extrinsic muscles of the tongue, the base of the tongue, kind of those extrinsic muscles attach here in order to move the tongue. It has a body right here. You can see the main body of it, and then it's got these cornu, or these horns. There's a greater horn and a lesser horn right through here. And again, these are just horn in Latin is cornu. So sometimes some books you'll see it's named cornu instead of a horn, but that's just a site for muscle attachments there. Okay, let's finish up today talking about some fontanelles and the jaw. The fontanelles, 6 fontanelles, 6 soft spots on a baby's skull here. The cranial bones are formed by intramembranous ossification, and initially there are 2 frontal bones. You can see here there's even 2 frontal bones here initially as they join and fuse together. The anterior fontanelle is a big one here. This one gets a lot of press. This is an important one. If you've ever taken a babysitting class from the Red Cross, they tell you to be very careful of the anterior fontanelle. The reality is there's several other fontanelles here, so there are 5 others. So let's talk about these. But the anterior one can sometimes, you can see a pulse right underneath here. Remember that superior sagittal sinus goes right down the middle here. So if this is still kind of open and just kind of soft tissue and skin covering that, not really ossified underneath, you might see the pulse underneath there from that superior sagittal sinus. This can take up to 2 years before it completely ossifies, that anterior fontanelle, before the frontal bones and the parietal bones really fuse up together nicely. The posterior fontanelle you can see back here where the 2 parietal bones meet the occipital bone. Right there, ossifies much earlier, about 6 to 8 weeks after birth. This one's pretty much sealed up. So that one's pretty solid at that point. And then let's go from a side view here. You can see, isn't an infant skull just cute? Still color coordinated too, I love that. Somehow the frontal bone turns blue, though, apparently, later in life. But the anterolateral fontanelles, this one right here, this is the big one between the frontal, the parietal, the temporal, the sphenoid, right through here. The frontal, parietal, yeah, the temporal, anyway. This is at that pterion. Remember the pterion where that comes together? And maybe it's because there's all sorts of interactions that need to happen here that never really ossifies completely, but it does ossify and become firm at about 3 months after birth. But again, it never gets very hard or very thick there. It's a pretty vulnerable spot. And then the posterolateral fontanelles. Again, there are two of these, obviously. This is the right side. The left side would have one as well. The posterolateral fontanelle, where the parietal and the temporal and the occipital bones meet up. Not many people pay attention to this one because it's covered by hair. Typically, if a child is growing hair behind the ears, it's tougher to see. But again, this doesn't ossify until about 2 years either. So the anterior and the posterolaterals are really pretty vulnerable. But this one gets a lot of press. This one doesn't get as much. Anyway, there's a vulnerability, though, between all these until they're completely ossified from that. They form, there's just a membrane to the bone here. So just being very careful of those spots on an infant's skull and young child, up to 2, a toddler. I think toddlers go to 3, but be careful until they're ossified. Okay, let's just finish real quick here and talk about the jaw, the TMJ, the temporomandibular joint. This is just a very unique joint here, and it has it's not just a hinge. You think, oh, it's just a hinge. It just opens back and forth, but there's a gliding component to this as well. There's a fibrocartilage disc that sits right inside between the temporal bone and the condylar process of the mandible. Oh, I tried to hold it. Excuse me. There's a disc that sits in there, and so when you depress the jaw, when you open the jaw, there's going to be the condylar process is going to glide a little anteriorly. So it's going to hinge, but it's also going to glide anteriorly open like this. So it's going to shift that disc open like that. Now, if you have some laxity of this lateral ligament here, the lateral ligament of the jaw, that is designed to help stabilize the jaw, holding it to the temporal bone here, the condylar process. But if there's some laxity there, either from congenitally or from childbirth, if you've got some relaxing hormones in the system still after childbirth, a lot of young mothers will have TMD, temporomandibular dysfunction. There's also some muscles in here, the pterygoid muscles that will come over and attach from those pterygoid processes, and they can sometimes get quite irritated inside the jaw. So the temporomandibular joint can provide discomfort and dysfunction. So when people say they have TMJ, you could say, oh yeah, you've got 2 of those. What they really mean is they've got TMD, temporomandibular dysfunction, where there's some laxity at the ligaments, and there's some dysfunction of that fibrocartilage disc, and maybe some muscle imbalances there as well. Well, that's it for the skull. Oh boy, I apologize, 1 hour and 6 minutes. I hope this was helpful. I hope you learned something. I really look forward to going through this with you in lab, and I will talk to you then. Thanks for your time.